I think I'm thinking about the whole piece and what it means for me to make a plan for a patient, not just individual drugs. And it has to be all accessible.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
I've been doing great. You know, Hadar, I've been thinking ever since residency, do you remember the good old days when we had nothing to treat nothing? Well, that's changed a lot, hasn't it?
Oh my God, if it's wet, dry it. If it's dry, wet it. And if it's inflamed, put some topical steroid on
Enough
it, right?
about your nephrology dreams, my friend.
Well, those were the days. No, they were not the days. They were horrible days. Now we have so many more treatments, a lot of efficacious treatments that really change the lives of our patients. In fact, Raja, so much so, it becomes really challenging to choose, especially in eczema and psoriasis. We have so many drugs, and sometimes I'll be honest, I have a confession to make. I'm a little befuzzled.
You just need to get a dartboard, my friend. But I think we have a better way to do this than dartboarding it, right?
Oh, save me, please save me.
And guess who we have? We have the man, the dermatologist, the legend, and the repeat friend of our podcast. And of course, we know him very, very well, Dr. Peter Leo, who is such an influential guy, publishes like crazy, awesome mentor to a lot of people, and also an expert at really diving into the clinical aspects of dermatology. He's a clinical assistant professor, dermatology and pediatrics at Northwestern University. He also is the founding director of the Chicago Integrative Eczema Center, and he is a leader in integrative dermatology, which we know he's one of the key faculty in the integrative dermatology certificate program, has over 400 publications, 4 textbooks. And I finally got to take a breath. Peter, welcome to the podcast, my friend.
Thank you guys so much for having me back.
Welcome again. And I would say he is a star, which leads us to what we want to talk about today. Because, Peter, I think you told us that you've developed some kind of a way to think about how to choose effective therapies, I assume together with the patients. Can you tell us, first of all, how this came about? So what kind of happened in practice that triggered you to say, my gosh, we got to think about this differently?
Absolutely. You know, I love the way you started it, that we had nothing for nothing, right? And if it was dry, wet it, and so on. So we were in trouble. And especially in atopic dermatitis, a pretty terrible condition that tortures patients and families for years and years. We had very little. But in the last few years, really, I would say that kind of the modern era kicked in. You could argue maybe 2016 with crisaborole or 2017 with dupilumab. But now we're in this time of bonanza. We have a lot of choices to make. And my struggle is how to, in a very confined amount of time, we're lucky if we have 15 or 30 minutes to talk to the patient. How do we present these options? How do we do a shared decision-making process together to get where we need to go when you have all these different things and all these different notes? And of course, every company, to their credit, to some degree, they've spent a fortune in developing these and a fortune in marketing them, but they're all trying to pull our attention, say, oh, pick our drug because it does X, Y, and Z, and pick ours because it has a better safety, and pick ours because, and it can become overwhelming. So I thought, what are the real fundamentals? What are the key things we can talk about? And I came up with this idea where we can kind of boil it down to ESTAR or ESTAR, if you want to use the Spanish word for to be, but it really is just those 5 concepts: the efficacy, the safety, the tolerability, the accessibility, and then this concept that I think is emerging and really exciting to me, the potential for remission or a remittive effect.
Amazing. I'm writing these down as you speak. And perhaps you can give us a sense of how this comes into play in clinic. Maybe you have a prototypical kind of patient that comes through and very confused, or you could have many choices in eczema. Sometimes for most of us, we see a patient, they're very severe. It's almost clear like where you're going to go. But there's those that kind of fall right there in the middle, right?
Exactly. And I feel like part of the challenge is we're in this betwixt and between phase. In the future, I truly hope and believe that we're going to get to that point of true precision, personalized medicine, right? Where we're going to be able to use our tricorder and look at the patient and say, okay, you have this genetic issue, you have this environmental insult, you have this epigenetic change. So the right medicine for you is going to be XYZ because it will meet your needs the best. It'll match you up correctly and it will minimize your risk of side effects. Well, we're nowhere near there, but we're also not at the beginning of the path where it was like, here's a corticosteroid, which will do kind of everything. Corticosteroids work for every inflammatory thing we can think of, plus
Yep.
some cancerous things, right? Like it sort of shuts everything down. But we're in between. And I think that's what's so fascinating. So, how do we quickly and efficiently decide a little bit about each one? What are the key points in that room?
And so, can you take us maybe through an imaginary patient, how the conversation would go using this acronym or this kind of decision support tool, if you will?
Yes, I would love to. Okay, so certainly I think this would apply for a number of conditions that we treat, like psoriasis. There's a bonanza of all the different biologics and, of course, some really good oral agents as well. But my main focus is atopic dermatitis, so I'll use that because my comfort there is really the highest. But for example, today I had a patient who has already been on basically all the topicals you can imagine, right? They've used lots of topical corticosteroids. They've used our calcineurin inhibitors over the years. They were not able to tolerate crisaborole. They've even, in my care, tried some of the newer agents. We have just in the last couple of months here, we've gotten a couple of new topicals with our topical roflumilast and our topical tapinarof just a couple of weeks ago approved. And we even have a topical JAK inhibitor from the past couple of years with our ruxolitinib. So they've kind of been on all that, and they've been on dupilumab, but had some issues. They had conjunctivitis, and now are saying, well, I heard there's a couple of new medicines, right? We have some new alternatives to think about. They have not been on the JAK inhibitors. So we have abrocitinib and upadacitinib. They also now are aware of the two newest biologics for atopic dermatitis, which are, of course, lebrikizumab and now nemolizumab, again, very recently. So we had just a few minutes to kind of sketch out what are the main differences between these. So I went through each one. And what I do is I actually make a little radar plot. So it looks like a little, like a little spider web or a web. Sometimes I even call it like a web plot, where we have efficacy, we have the safety, the tolerability, and the accessibility and remission on these little axes. And then we can actually draw like a little shape within that radar plot. So I can say, okay, let's talk about, for example, our JAK inhibitors, right? Those are fabulous drugs, right? They work really quickly. They're very powerful. I give them on, so I kind of have this from 0 to 5. So I would say if we take upadacitinib, I think its efficacy is probably a 5 out of 5. It's one of the strongest things I've seen. So we kind of put that there. And then maybe we compare it to, for example, if we're comparing it to nemolizumab, maybe nemolizumab, when you look at the data, and I have somewhat limited experience so far, I have a number of patients on it, but maybe I'd put that like a 3. So it's pretty good. It's not quite as powerful. It's not quite as quick as upadacitinib. But when we go to the safety category, okay, the next one over, well, now I'd put nemolizumab probably at a 5 out of 5. It's one of the safest biologics we have. It has very, very low safety signal in general. It's not perfectly safe. Nothing is, but I would say it kind of meets the criteria for what we think is possible. Whereas upadacitinib, maybe a 3 out of 5. And part of the thing here is obviously these are not absolute numbers. I'm not basing these on a particular paper that I can cite. I'm doing this with the patient. We're sort of talking it through, and I'm saying, well, with our JAK inhibitors, we have to do some blood monitoring. There are the boxed warnings. So we kind of hashed it out and we say, okay, let's call it as a 3. So we put that there. Now, another patient might say, oh, no, black box warning for me, and I don't want to deal with it. I'm going to call that a safety of a 0. I don't want to deal with that. So that could be a deal breaker right there. But this is the process. So we go through these aspects, and by the end, we kind of have this representative shape on the paper where we can say, okay, what do you think? Which one is speaking to you more now that we've kind of talked through these in a structured way? And again, this is only a couple of minutes. We're not spending hours. Nobody has hours in clinic, but over a couple of minutes. And then at the end, they can make a decision. And some of the patients might say, I want to try lebrikizumab. I want to try nemolizumab. Or another patient might say, you know what? I really, really need to get better quickly. So I'm going to put some more emphasis on that. Can we please start the upadacitinib or the abrocitinib? And that's fantastic. And the other piece I'll say is that now that they know this, we often say this is not a permanent choice. This You're not married to this medicine. We're going to try this for a while. And if things aren't working out, if you're not doing as well as we hope, or if you're having an adverse reaction, then we have the opportunity to change. So now you've heard about both of them and we've kind of framed them in this way that really, I think, illustrates the key pieces. And I'm so excited about this. And I can't tell you how successful this has been, that we're actually writing this up. I wrote a similar paper a few years ago that was the same concept. We called it EAST at that point. And I've added this concept of remission because I feel like this is the next frontier. And I love to bring that into the discussion as well.
Well, Peter, I think this answers one of the age old questions that we've had. First of all, this was awesome just to hear you walk through how you might use this to help make better decisions. But then it really brings the question of Hamlet back to dermatology, ESTAR or no ESTAR? And I think that we now have an answer, right? You should always choose ESTAR.
Absolutely. Yeah. That's really good. I really think that what I like about this system, Peter, is that you're bringing the patient point of view into this and they get to choose with you as the ultimate information provider to choose if this is really for them a 0, a 3, a 5, right? So it really brings in the patient value system into play as well, which makes this a really powerful tool. Do you find that patients vary in their perspectives on what's important? I think, a lot of times it's the efficacy and safety. I'm surprised sometimes you see people who are doing really, really poorly, and you would think that all they care about is efficacy, and vice versa. People who do have relatively mild disease wouldn't care so much and really want to just use something safe. But I've been humbled before. Do you find that now that you kind of do this more systematically, have you been surprised?
Very much. And I will tell you a story. I got to be part of the Joint Task Force of Allergy and Immunology guideline document. So we know our American Academy of Derm,
I read
the
it.
right. Okay. So I was the token dermatologist and it was fabulous process. And the cool thing was it's actually done a little bit differently than the American Academy of Derms in that we actually have some patients sitting in the panel. So the patients, like I know AAD, they definitely talk to patients. That's part of the discussion, but they're not really in the decision making group. And one of the things where this came out was if you look at our guidelines, it made a little bit of a stir. It caused a bit of a stir because the Joint Task Force, the allergy guidelines, actually classify topical ruxolitinib, right? I think a really great topical medicine that's FDA approved in the United States for atopic dermatitis. It's great. Of course, in the AAD guidelines, it is, I think it's conditional recommend, but in the Joint Task Force and the allergy ones, it's conditional recommend against. And this caused a bit of a stir and was like, wait a minute, why? Why are you recommending against? Well, it turns out if you really dig in, it was because the
Mhm.
patients on the group felt that the box warning was off-putting enough to sort of give them pause. And I think that illustrates your point exactly. And I don't know if all patients would agree with that. Of course, I'm sure all three of us use it. Many of my patients say, heck no, I want to try it. It sounds reasonably safe. And I understand the warning is there, but there's also a warning on the calcineurin inhibitors too, right? I mean, they have a boxed warning as well. So I think it can be patient dependent. It was just kind of fascinating to see that writ large in that patients who were having a real voice on the guidelines got to influence it. And it actually resulted in a letter. The AAD wrote a letter, and hilariously, I was on the letter. So I kind of got to write the letter to myself because I'm part of the expert resource group for the American Academy of Dermatology. So it was fun. But I thought it was a good experience. And it really showed us how good people, expert groups, well intentioned, trying to get to the truth, they can come to slightly different conclusions. I mean, they weren't dramatically different. One wasn't saying this is
Right.
going to poison everybody, and the other one saying they should put it in the water. No, but they were slightly different. And I think that's really important. I think that's honestly instructive for everybody looking at guidelines that they're a guidance document and that they really do represent a group of people coming to a conclusion. They are certainly not perfect, and things change, right? Because they were written at a point when we had a certain amount of data. And my hope is that with more data and more comfort, I think that the Joint Task Force will actually soften that and say, okay, I think we can recommend it because those risks, while real, I would never totally say that they're not real. They are real risks. I think that they're incredibly low risks though. And as we get more experience, I think we see that.
Now, Peter, I want to make sure that we cover everything. So we talked about efficacy and safety in the ESTAR system here that you have. And I think that's pretty intuitively clear to people. That's kind of what we read about all the time. It's the number one, number two questions we always have. Talk to us about the tolerability part, accessibility, and remission. Guide us through what does the conversation look like? What things should dermatologists look for when they explain to patients tolerability, for example?
I love it. And thank you, Hadar, because I think a lot of times we're kind of trained to just lump safety and tolerability together, but they really are different, right? So when I talk about safety, I'm saying this is potentially dangerous to you or your health. This is something that could potentially have an effect that could put you in danger, as opposed to tolerability, which in general, to me, is something that might be unpleasant, but certainly it's not going to cause any permanent damage. It's not going to put you at any real health risk. So a good example of this, I think, is the ocular surface disease associated with really all of our IL-13 biologics. So dupilumab, tralokinumab, lebrikizumab, all three of them do seem to have some degree of this conjunctivitis, keratitis, kind of eye issues. And I have had patients, honest to goodness, who've come in and said, I'm very afraid of these because I don't want to go blind. And I'm like, wait a minute, where did you hear this? And they say, oh, well, somebody told me this. It can damage your eyes. And I said, okay, listen, yes, it is possible, I suppose, if we let it rage for a long, long time, you could get some scarring. But let me be clear, this is mostly a tolerability issue, right? This is going to be, it could be uncomfortable, your eyes could be red, but we can stop the drug. And in general, you're going to do fine. So it's so important to separate these. Or with tapinarof, topical tapinarof, right? The safety is really good. Now, the tolerability, there's this follicular process that can happen, right? Sort of a folliculitis or follicular occlusion. So I think that's important as well. It's not necessarily dangerous, but it might be harder to tolerate. Similarly with crisaborole, a very safe medication, now approved down to 3-month-old babies, but maybe not always tolerable. It can cause quite a bit of burning and stinging. So separating those out, not that they're any less important, but I do think it's worth separating those and explaining to patients. And sometimes a patient who's afraid of losing their vision, right, which I think is pretty darn unlikely and not really what we're talking about when we talk about conjunctivitis or blepharitis or dry eye. I think they might say, okay, and if I have this tolerability issue, this is something we can work on.
Peter, how do you build in insurance coverage into this model? Or
Yes.
do you just kind of go down the line if the insurance says no, or do you appeal? Like, how do you approach that?
And I think that's it. And this is the key of access, because I think we're kind of trained, we're consumers in the United States, and we are just used to thinking about the dollar sign. How much is it? But my point about access is that the dollar sign doesn't mean that much. I mean, a medicine could be $30,000 and yet very accessible, right? They have a manufacturer coupon, coverage is great, and everybody gets it for $0. Like, that's really accessible, right? And on the other hand, you might have something that's $300. Well, that's not that expensive for a medicine that could affect your life, but nobody can get it. And literally, I'm using those examples, but those are real things. For example, we know tacrolimus and pimecrolimus, right, our TCIs. Well, those are generic. They're not that expensive, but they're a few $100s per tube. And I have so much trouble for some patients getting them covered, because if they're not covered by insurance without a big fight, $300 a month is too much. People won't pay it. Meanwhile, I'm getting biologics, which literally can cost $30,000 plus per year. And even if insurance doesn't cover those, though, or whatever they cover, we have copay assistance programs and we have patient assistance programs. So I am almost always able to get it, even for my public aid patients, Medicaid patients. I can get dupilumab. Almost, I don't think I've ever had a true failure on it. So it is really remarkable, the range in experiences, and that's why, as a clinician, yes, I'm trying to be a good steward of healthcare dollars. I really am. I'm not trying to burn money for fun. But on the other hand, my primary job, in my opinion, and I get it. I mean, if you want to work for the system, I get it. This might not be, this sort of, the bosses don't like this, but I work for my patient. Like, my patient is the most important thing. So while I care and I'm not trying to be wasteful, I also am trying to do the best thing for the patient. And I get it. The system would prefer me to just be a little cog in a wheel and a worker bee and says, what's cheaper for me? And of course, that answer is different for every darn insurance company. And that's the joke too. For one insurance company, they have a great deal with such and such drug. Another one might have a different drug. So I can't know all these things, nor do I want to. I don't want to study them and say, for this particular insurer, I know your drug of choice and your PBM really prefer, right? It's not my job, and not my, one day maybe we'll
No,
have to to
I,
practice,
I
but
tell my patients I completely failed the law school part of medical school.
Me too. Absolutely. But that, right? So that's the complexity of access. And I think for all three of us, we have an interest in integrative health as well. And one of I think the reasons that some patients get pushed towards integrative things is because this is a very difficult maze, and it can be very, very trying to navigate all of these access issues. And sometimes when you're just recommending coconut oil or soaks or even something like acupuncture where it's going to be out of pocket, it sure simplifies everything, doesn't it? It gets very simple. It's like, you know what? To pay a few $100s for this thing is reasonable, or to get this thing over the counter that's very accessible. That plays a role in this too. So I'm thinking about the whole piece and what it means for me to make a plan for a patient, not just individual drugs. It has to be all accessible. Of course, part of that even can be to getting access to those things in the first place. So, for example, I love phototherapy. I do a lot of phototherapy, but it is not always a great fit. If somebody drives an hour and a half, well, that's not going to work for 3 times a week phototherapy. If somebody's traveling all the time and has to be on the road, well, that's not going to work. So, all of these pieces go into access, right? It's a really important point. And again, that's the only way you can have that discussion is on an individual basis. What is your setup? What is your lifestyle? What is your insurance coverage? What is your ability to pay for out of pocket for things? And we have to make that as a sort of a individualized discussion, and that can change as well. So we understand that.
I think that's really a key important part of the discussion. I want to make sure that we cover the last part, which is the R in the STAR, and that's remission, which I think, a decade ago would have been something we wouldn't even include in the discussion in most inflammatory skin diseases, but now we can do that. So, how does that conversation go? And maybe you can separate it from the efficacy.
Yes, so this is the most exciting thing. And I think I will disclaimer first is that there is still a lot of discussion happening about what do we mean when we say remittive effect or remission? What are we even talking about, right? So I think we can start with the idea of a cure. Or a cure would be a dream where we give somebody a medicine for some period of time and then we can stop the medicine and the disease is gone. It's like you just, right? We cure a staph infection all the time. We
Right.
can cure skin cancer to some degree, largely. But we can't really cure atopic dermatitis. That'd be amazing. But between there and not helping at all, there's a big range of things, right? So I think there is clinical response to a treatment. There is durability of response. Okay, so a durable responder, it's like, hey, you've been on this drug for a year and you continue to do great. That's fantastic. But still, to me, that's not remission. Remission, I would define as seeing sustained improvements over the baseline, even as we decrease the amount of drug given or the amount of drugs. So sometimes that could even mean, when we started, you needed to be on dupilumab plus triamcinolone, and your other topicals. Well, now you're only on dupilumab, right? You don't need any topicals. Your skin has been so good in the last 6 months or something, or decreasing the dose of the medicine we're giving them, right? So maybe now we're using half the dose. You needed upadacitinib 30 for a while, but now you're down to 15. That's a win to me. That's a relative remission. And then with our biologics, it often means spacing out the dose. So with dupilumab, there is no approved dosing, frequency change for it in the United States. But we know that with tralokinumab and now with lebrikizumab and Nemo, all the followers, I think, saw that, patients could decrease their dosage when they were doing well. So they all have codified, FDA approved, labeled guidance for decreasing the dosage, right? So for tralokinumab, you can decrease to monthly dose from every 2 weeks. Same with Lebri. And with nemolizumab, really remarkably, that's a monthly drug from the beginning. But when they're doing better, when they achieve that clinical endpoint you want them to, you can go to every 8 weeks. So this is a big deal. And I do view this as a form of remission. Although, again, I understand that everyone's definition can vary. We don't have a complete agreed upon thing, but that means a lot to my patients. And the idea that that can happen is a big deal. Now, what am I comparing this against? Again, because it's all relative and a lot of it's experiential. Not everyone's going to get there. And I never would overpromise that. But when we talk about, for example, compared to if you're on corticosteroids by mouth, I actually feel like they can be kind of anti-remission, right? We can actually see exacerbation of the disease, even a rebound effect worse than the baseline. And a lot of my patients have sort of been burned by that. They say, I kept getting course after course of prednisolone or prednisone or intramuscular triamcinolone. And it was so great. I felt so great. But when it wore off, I was worse. I was even worse than when I started. And I was in this cycle of worsening disease. So I say, listen, I hear you. I believe you, and I completely agree. And what we're interested in are medications that go the opposite direction, that are going to let you go towards remission, at least have the potential. And when we talk about this, I'm telling you, it has opened up the door even to patients who are quite afraid of different treatments, sort of medicine phobic. I get a lot of those patients who are treatment hesitant. But when I talk about this, I think patients say, okay, I love this idea. And I never promise it. I mean, not everyone's going to get there, but there is no doubt that there is at least a group of patients, and I've written some papers about this, that can achieve that improvement and then are actually able to wean the drug, at least decrease, increase the interval, or come off completely. And I think that is incredibly exciting.
Yes, I think this is so important to add to our discussion in dermatology in general. I think we're obviously talking about atopic dermatitis right now, but you can easily, as you mentioned earlier, translate this concept of remission to acne. Some patients really, and now it's clear to me how you separate it from the efficacy because I know, I mean, the simplest example with isotretinoin, I think patients would be hesitant to say, do I really have to come to the office or at least get the prescription every month if you do blood tests or pregnancy tests and all this work, but then you add the element of remission, and voila. Even in psoriasis, I've at the last AD, Andy Blavelt, his work with Skyrizi, which is really impressive, trying to really induce remission with high doses. I think it's really a concept that's going to be real for us in dermatology, for sure.
Well, now I have a question here. Now, we all do integrative medicine as well, Peter. So, how do you bring in the integrative piece into this when you start thinking about, whether it's supplements or what about the role of phototherapy or what about these other approaches that some of them are proven, some of them have early pilot studies, some of them have, multiple studies, but perhaps not an FDA approval. How do you approach that kind of scenario?
And Raja, this is my favorite part when we get to really talk about how we can make something more integrative. We can start with our bread and butter, our conventional therapies, and we lay those out. And then we're sort of painting the rest of the picture in with some of these integrative approaches depending on their needs. And I obsess about this idea of breaking diseases down to therapeutic pillars. So we talk about for acne, the idea that we have follicular occlusion, but we also have increased sebaceous output. We also have inflammation. So we can kind of take those as pillars that we can then use things that are in the integrative domain to address some of those pieces. In atopic derm, of course, we have our skin barrier dysfunction, our microbiome dysbiosis, we have inflammation, itch, and then we have the mind body piece. So I'm trying to put all these pieces together for each patient. And then I actually truly believe that that will allow us to get to at least a pharmacological remission. So even if a patient is using acupressure, or if they're using some botanicals, or if they're using a supplement, or maybe they're doing a mind body technique, that's okay. If I can decrease their overall medicines, maybe they're able to come off topical steroids. Now they can get by with only non-steroidal agents, or maybe they can come off their systemic agent, which is amazing. So to me, that is again another form of remission. It's sort of a de-escalation of therapy. And again, depending on who you're talking to, this may or may not be important. Some patients don't want to hear about it. They're like, just get me better. I don't care. But many of my patients really are sensitive to that. And what really, I think the magic happens when you're able to take a patient who is completely out of control and miserable, get them under control, then get them under control on less and less and less medication. And they are just feeling so good and they're so happy and they're in this remission, which I find can be quite durable. And I have now patients who have been off dupilumab for years. They've been off it for years. They were some of my worst atopic dermatitis patients, and now they're off it for years. That means something, and that is powerful stuff. And I think that's what I'm all about. I always tell them my job, if I do it correctly, is to be a distant memory when you say, oh yeah, what was that dermatologist who helped me? He was really nice. I can't remember his name. I haven't needed him since. That's when I know I've done my job. I don't want to be a part of your life
That's
because that means I'm not doing a great job. I'm not getting you better.
Excellent. Well, listen, folks, when I was in medical school, I think one of the best lecture I had was talking about two concepts, speaking about being in a relationship. And the lecturer came in and said, students, you're going to have to meet your two new best friends, ambiguity and uncertainty. And I think as clinicians, it's always like that. But now we can maybe take that out of the equation a little bit with, you guys heard it here first, the ESTAR from Dr. Leo's incredible mind: efficacy, safety, tolerability, accessibility, and remission. Don't forget to have that discussion with your next patient. Try it out. Let us know what you think. Peter, thank you again. I think you are one of our you're leading the score, I believe, on guests on this program. Soon we're going to have to start paying you some benefits here. Well, thank you very much. As usual, pleasure to have you here, and I'm looking forward to future conversation. Thank you.
Thanks, Hadar. Thanks, Raja.
agreed.
And that's a wrap for today's episode. But hey, Raja, every time we dive into these conversations on the podcast, it feels like there's still so much more to uncover.
Exactly, Hadar. That's why I look forward to the IDS every year. It's the best conference. I'm biased, of course, but I love it. It's the perfect place to continue exploring the latest in research sharing ideas, and learning how to apply integrative strategies into a real-world dermatology practice.
I agree. And you know how every year we like to have a theme? Well, this year's theme couldn't be more relevant. Ready for it? Here it comes. Guide your patients towards a healthy biome and optimal skin health.
Love it.
Yeah, because we know that skin health isn't just about treating the surface. It's about understanding the entire biome and how it connects to overall health.
And that's exactly what we'll be tackling at the 8th Integrative Dermatology Symposium happening from August 22nd through the 24th at the Westin La Paloma Resort and Spa in Tucson, Arizona.
We've got an amazing lineup of expert-led sessions covering key conditions that you see in clinic every day, like eczema, psoriasis, vitiligo, prurigo nodularis, chronic urticaria, and melasma. Plus, we have great insights into how movement, weight loss, and even coca polyphenols can impact skin health.
Well, who doesn't want some good cocoa polyphenols? And what really makes IDEAS special is the interactive format. We're not all just sitting around through lectures. We're more interactive. We have real-world case discussions, hands-on workshops, and plenty of opportunities to connect with colleagues who are just as passionate about integrative dermatology as we are.
And let's not forget about the location, all right? This is the Westin La Paloma Resort and Spa. This is the perfect place to learn and recharge. So you can explore scenic desert trails, relax by the waterfalls, stargaze under the Arizona sky, play a round of golf or tennis, or just simply unwind at the spa. And of course, we'll have our usual spectacular evening receptions where you can catch up with colleagues and make new connections.
Oh yeah, I can't wait to be stargazing and whispering sweet integrative nothings to each other. Now that sounds like the ideal way to learn, recharge, and connect all in one weekend. So if you haven't already, head over to integrativedermatologysymposium.com to check out all the details and save your spot.
That's integrativedermatologysymposium.com. We can't wait to see you at the IDS 2025 in Tucson, Arizona. Let's take integrative dermatology to the next level and do it together.